Okay, so we're going to switch gears now from cone beam, and what we're going to do is talk about tomosynthesis. And I don't think a lot of physicians understand exactly what tomosynthesis means. I know Dr. Shah said that cone beam CT was basically a Lamborghini. I said it was a Bentley because it was more luxurious, you get in it. However, I have access to every robotic platform that's out there. I have body vision, I have everything. However, I do not have access to our fixed cone beam suite. Our IR people are so busy, we only get to use it when they decide to go on vacation, which isn't that often. And those of you that are in Europe know that you don't need a Bentley to get around, although it would be nice, but you guys have got a great train system that gets you around and gets you exactly what you need. And that is what my comparison is going to be between cone beam and tomosynthesis. So what exactly is CT chest imaging? So a conventional CAT scan imaging has a patient laying on a table. Underneath the table, there is a fan beam detector, and the CAT scan machine spins around the patient 360 degrees, and that is how you get your 3D images that we get every day when we're in our office and we're seeing our patients. This is not cone beam CT. The word CT is only there because of the computerized tomography part of it. So all the other imaging that we have routinely in our bronchoscopy suite, including cone beam, is a fluoroscopy machine. It actually is a 2D fluoroscopy machine. Every fluoroscopy machine has a cone beam emitter in it, so your regular fluoro machine has a cone beam emitter in it. And then what determines if it is cone beam CT versus tomosynthesis is simply the amount of the spin, the degree of the spin that you're doing around the patient. So if you take your machine and you're doing a 200-degree rotation around the patient, that is what is cone beam CT imaging. However, if you're only going 30 to 30, so a 60-degree spin around the patient, you're taking those 2D imaging, you're going into a processor, making it 3D imaging. This is digital tomosynthesis. This is the difference between the two. Cone beam CT, I said, not the Lamborghini, again, the Bentley. This is the train. They both get you what you need. It's just the amount of imaging that you're getting and the clarity that you're getting with the imaging that you're seeing. So you might say, well, where did digital tomosynthesis come from? It's been around for a long time. It's typically been used in breast imaging. What they have is they have the machine, it spins around, all the images get collected, they get reconstructed into an algorithm, and then you can see nodules or whatever it is that you need to see. This is how we got it into the chest. So the same thing can be applied to chest imaging using exactly the same technique that you see here. And this is how you can see nodules, you can see your tool and lesion, you can see your robot, you can see whatever you need to see. The difference is your depth of focus that you have. So the cone beam imaging is deep, you have a lot of clarity, you have a lot of imaging. However, do you need all that imaging when you're biopsying a nodule? All you really need to see is the nodule. You can perfectly see that dog in tomosynthesis imaging as well. It's more shallow. What it does is it blurs out everything that's in the background that you don't need, and it focuses on what it is that you need to look at, as long as you are iso-centered on the image of interest that you're looking at. So what you're doing is a 30-degree spin. You're iso-centering your beams onto the nodule or where the lesion is. So it's very important that you have the ability to be able to iso-center exactly where the nodule is. You might say, though, I don't know where that nodule is. How do I find that nodule? Well, you have your CAT scan imaging. What you do is you kind of have an understanding of where it is. And we do have technologies now that really help you iso-center, which I will show you. But what's important to know is that as long as you're within 25 millimeters of that nodule, you get really great imaging. And in fact, even up to 40 millimeters. So when you are going out with your robotic scope or your scope, as you start to look at your imaging or doing your tool and lesion spins, when you're about 20 to 30 millimeters away from the nodule. And that's how you know that you're iso-centering around the nodule so that your imaging is really great. There are technologies out there that actually tell you exactly where that nodule is. So you guys all saw body vision cases yesterday. After you do your spin, it tells you exactly the height of the bed, where that nodule is, how to fix your fluoroscopy machine. With the Galaxy system and the Illumisight system as well, what you're doing is you're getting within 20 to 30 millimeters of the nodule. You're basically, the tip of the scope is within where the nodule is, and you're isocentering. Ideally, you're isocentering around the scope, but you're getting really great imaging of your nodule as well because you're within range of where that nodule is, and that's how you're isocentering. So these are images that I have, CAT scan images as well as tomo images. And you can see here very clearly that the images are pretty comparable to each other. Now, I didn't tell you which one is the CAT scan. I didn't tell you which one is the tomo image. I think you guys can pretty much tell, though. There's your pre-op CT scan. Here's your SIOS spin, but this was not a full spin. This was a 30 to 30 degree spin with the SIOS machine. You can see how nicely you can see that same nodule and how well you can see it. Here's a different fluoroscopy machine, again, showing you tomo imaging that you can see. This is your GE 9900. Again, tomo imaging, isocentering on the lesion, you get very good imaging here. This is even a different platform that a lot of you may have out there. Again, pre-op CT, and this is your GE. Again, not a full spin. This is a tomo spin from 30 to 30. Again, you very clearly and nicely can see your lung nodule. You may say, though, how accurate is tomo compared to cone beam? So we do have data, because most of this has been done in the breast, and they have been able to show that you are actually within 1 millimeter between your cone beam and your tomo images. So for us, we're not doing 2-3 millimeter nodules. We're doing nodules that are much bigger than that. So I would say 1 millimeter is perfectly fine to be off for me to be able to get a diagnosis if I'm doing tomo imaging. Across the top here, this is all cone beam images that you're seeing. So these are the different cone beam images you can see across the top. On the bottom, you have your Galaxy with the GE 9900 image here. You can see how nicely you can see your tool and lesion, and you can see your nodule. Here's your body vision with the GE 9900. Again, you are getting the information you need, and you are seeing exactly what you need to see, which is where am I in relation to that nodule, and is my tool in it? So the platforms right now that have the ability to do this are Illumisight, Lung Vision, and Galaxy have these built in with the tomo imaging. When you look at radiation, a lot of the data we have is from the breast. Again, we know that you're going to get more fluoroscopy and more radiation, and there's more data to come on that in the lung that we'll see in papers that are upcoming. So with DT image integration, you can target locate, you can update your lesion, you can get augmented fluoro, which Dr. Cecilia is going to talk about next, the importance of that, and you can target exactly where you need to be in the middle of the lesion. So if you compare the two to decide which one is it that's better, I think I showed you the image quality for both, pretty good. Spin and processing time, digital tomo, less images, lesser spin, under a minute. Cone beam CT, I have a SIOS. It takes a couple of minutes for you to update your imaging. Obviously, you're going to have less radiation with tomo. Cost is obviously going to be cheaper. You're going to use the fluoroscopy machine you have. You don't have to go out and spend however much money it costs to get a mobile cone beam or to have access to your IR suite. You're going to have augmented fluoro with digital tomo. You may or may not have it depending on which cone beam system you have, and you're going to get tool and lesion with both. So a very good option to have with what you already have in your bronch suite without having to have any excessive extra cost with your robot. Works very well, gets you exactly what you need. And then this was my slide for the ABIP.